this week's ACCP Emergency Medicine PRN Journal Club presentation. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/ACCP-EMED-PRN. And for PRN members, slides can be found under the Business Documents section on the ACCP Emergency Medicine PRN website.
Dr. Temi Sofeso is a PGY2 emergency medicine resident at Boston Medical Center in Massachusetts. Her professional interests include emergency medicine as well as toxicology. Today, she will be presenting on tranexamic acid for intracerebral hemorrhage in patients on non-vitamin K antagonist oral anticoagulants, a multi-center randomized placebo-controlled phase 2 trial. I'll let you take it away, Temi. Thanks.
Thank you. Thanks so much for the introduction. Like Minden said, my name's Temi. I'm a PGY2 at Boston Medical Center, and today I'll be presenting on TICH-NOAC, a recent study that came out about TXA and intracerebral hemorrhage on patients in non-vitamin K antagonists. This is just a list of abbreviations that I'll be using throughout my presentation for your reference, and I'll be sure to kind of define them as well as the time comes. So to begin with a little bit of background, intracerebral hemorrhage by definition, intracranial hemorrhage by definition is any bleeding in the intracranial vault. And this includes the brain parenchyma itself or the surrounding meningeal spaces. I think it's important to denote the difference between intracranial and intracerebral hemorrhage, with intracerebral hemorrhage being a subtype of intracranial hemorrhage along with epidural, subdural, and subarachnoid. For the remainder of this presentation, ICH, the abbreviation, will refer to intracerebral hemorrhage. One of the most important risk factors for intracerebral hemorrhage is long-standing, poorly controlled hypertension, and this can lead to microscopic degenerative changes of the vessels and other pathological changes that can lead to vessel rupture. An example of another etiology would be anticoagulation. In patients that come in with intracerebral hemorrhage, the expansion of the primary insult, otherwise known as hematoma expansion, occurs in about 24% of patients within the first 4 hours of symptom onset. And this is what's been associated with unfavorable outcomes, and that really presents a narrow target window for us to intervene in these patients. Medically, we use things such as intensive blood pressure reduction and anticoagulation reversal, and these interventions are likely to be most effective when administered soon after the onset of ICH. When patients present with NOAC-associated ICH, they're at higher risk for hematoma expansion and neurologic deterioration, even more so than patients that don't come in with non-anticoagulant ICH. So prompt anticoagulation reversal is often necessary, but at the same time, it's really important to weigh this against the risk of thrombosis relating to their underlying need for anticoagulation. Our choice of reversal agent really depends on the anticoagulant the patient is receiving outpatient. For example, with our vitamin K antagonist, our therapeutic options would be vitamin K or 4-factor prothrombin complex concentrate or 4-factor PCC. With our direct thrombin inhibitors for dabigatran, we would go for idarucizumab. And then with our factor Xa inhibitors, again, we have the option of using PCC as well as their more DOAC-specific indexinate alpha. Our choice of reversal agent for non-vitamin K antagonists is really impacted by institution availability, specifically for our more costly options, idarucizumab and indexinate alpha. That, in addition to the lack of clear evidence regarding preferred treatment options to improve clinical outcomes in these patients, that's really opened the door to questions on if TXA might be able to play a role in these presentations. For a little bit of background, TXA or tranexamic acid is a plasminogen inhibitor, and this prevents the activated form plasmin from breaking down the fibrin clot. So really working in a distinct, unique mechanism different from our other anticoagulant reversal options. TXA has been around for a long time. It's relatively inexpensive, widely available, and it's been studied in a wide array of bleeding indications, including intracerebral hemorrhage that's not associated with oral anticoagulation. Before discussing any previous literature, it's important to briefly introduce the modified Rankin scale. This is a post-stroke outcome assessment tool that's been widely applied for evaluating recovery from stroke and used as a primary endpoint in a variety of randomized controlled trials. Its value is primarily due to its brevity, its simplicity of use, and its interpretability in the context of stroke trials. So it's a 7-scaled tool, and as you can see here, patients can present with a modified Rankin of either 0, no symptoms, to modified Rankin of 6. In recent years, a few randomized controlled trials have looked into TXA's role in reduction of hematoma expansion in ICH with a dosing scheme of 1 gram over 10 minutes, followed by a 1 gram infusion over 8 hours. To start off with the TICH-2 study in 2018, this looked at TXA compared with placebo in patients with acute intracerebral hemorrhage that presented within 8 hours of symptom onset. This was the first large multi-center randomized control trial that looked at TXA in spontaneous ICH, and their primary outcome was functional status measured through a distribution of modified Rankin scale, and they did not see a significant difference in this study. They did, however, find a significant difference in hematoma expansion, and they defined this as a change of greater than 6 milliliters or 33% increase from initial hematoma size, and they did see a significance in the TXA cohort. This finding is really what prompted the primary outcome for the next 2 studies I'll be discussing, starting with the STOP-OST trial. This was the trial that looked at patients presenting within 4.5 hours of symptom onset, as well as a positive spot sign on their CT angio. A spot sign, for those of us that might not be familiar, is a biomarker and a sign of extravasation on a CT angiography. This can be a biomarker of ongoing bleeding and a predictor of hemorrhage growth and poor outcome. Their primary outcome in this study was hemorrhage growth at 24 hours on repeat imaging, and they used the same definition of hematoma expansion as the TICH-2 study. The STOP-OST trial did not see a significant difference between the TXA and placebo groups. Lastly, in 2021 is the TRIAGE study. They similarly looked at TXA and hematoma expansion for patients presenting with ICH on admission imaging. They also used spot sign as a marker for their inclusion criteria in this study, but in patients with a longer time to presentation in the STOP-OST trial, so patients presenting within 6 hours of symptom onset. In line with the previous studies, they did not find a statistically significant difference in hematoma expansion in the TXA group compared with placebo. It's important to note that all of these trials excluded patients on anticoagulant agents. So this data really is unable to be extrapolated to that patient population, and whether or not TXA would be beneficial in anticoagulant-associated ICH is really what led to the TICH-NOAC study. So tranexamic acid for intracerebral hemorrhage in patients on non-vitamin K antagonist oral anticoagulants. As I highlighted in the previous studies, TXA has really only been looked at in non-NOAC-associated ICH, and little benefit has been shown in reducing hematoma expansion. Outside of NOAC, the NOAC-specific reversal agents, TXA's distinct antifibrinolytic mechanism is what presents it as an attractive option in this patient population. And so the authors sought to investigate TXA in addition to standard of care and its effect on hematoma expansion in NOAC-associated ICH. TICH-NOAC was a double-blind randomized trial in patients that presented with a non-traumatic ICH within 12 hours of symptom onset and last oral anticoagulant within 48 hours, or persisting NOAC activity. Some notable exclusion criteria were ICH secondary to trauma, treatment with vitamin K antagonists or warfarin, and severe pre-existing disability, which was defined as a modified Rankin of greater than 4. The intervention used in this study was TXA dosing strategies similar to that used in previous literature. 1 gram bolus infused over 10 minutes, followed by a 1 gram infusion over 8 hours. Participants received TXA or placebo in addition to standard of care, and this was considered to be blood pressure management, as well as the use of hemostatic agents at the discretion of the treating physician. Hemostatic agents in this case included NOAC-specific reversal agents, so idursulfimab and andexanet alpha, or 4-factor prothrombin complex concentrate, or PCC. The primary outcome of the study was, again, in line with previous literature, looking at presence of hematoma expansion on follow-up imaging at 24 hours. And they define this as an ICH volume increase by at least 33% or 6 milliliters from baseline. Notable secondary outcome they looked at was ordinal modified Rankin scale, as well as dichotomous modified Rankin scale of 0 to 3 or 0 to 4 at 90 days. In hospital death within 90 days, and major thromboembolic events, specifically ischemic stroke, myocardial infarction, or DVT and PE. In terms of statistical analysis, the authors' sample size was calculated at 109 participants needed in order to detect a significant relative difference of 50% in the rate of hematoma expansion. Between December of 2016 and September of 2021, 67 patients were enrolled in TICH-NOAC. Of those, 3 withdrew early before randomization and 1 withdrew immediately after randomization without receiving study treatment, and their data was unable to be used for analysis. This amounted to a total of 63 evaluable randomized patients, 32 of which were assigned to tranexamic acid and 31 assigned to placebo. Baseline characteristics for the study showed a median age of participant was 82 years old, and all participants were taking factor Xa inhibitors, with no patient taking the direct dominant inhibitor dabigatran. No patients notably received NOAC-specific reversal agents, while about 65% of total patients received 4-factor PCC. Some more baseline characteristics for your reference. Overall, the patients were reasonably balanced between the 2 groups, with the exception of lobar ICH being more common and time to study treatment being longer in the TXA group. I want to highlight that only 8% of total patients had a positive spot site on their CT angio, and this really differs from previous literature that emphasize a positive spot sign in their inclusion criteria. And again, a spot sign is a marker on a CT angio that demonstrates extravasation and higher risk of hematoma expansion and neurologic deterioration. So really just a higher risk patient population in this cohort. The primary outcome, presence of hematoma expansion at 24 hours on follow-up imaging, did not differ between the treatment arms, with 38% of patients in the TXA group and 45% in the placebo group showing hematoma expansion. This remained consistent in the per protocol analysis as well. The authors also performed a post hoc analysis that adjusted for baseline hematoma volume and time from onset to baseline imaging, and similarly did not see a significant difference with a p-value of 0.42. As far as secondary outcomes, none differed between the treatment arms. Neither the ordinal modified Rankin scale nor the dichotomous modified Rankin scales of 0 to 3 or 0 to 4 had any difference between the TXA and placebo group. And the authors observed no difference in major thromboembolic events in patients that were allocated to receive TXA. Of the investigated subgroups, there was an interaction, though not significant, between onset to treatment time and hematoma expansion, suggesting that TXA did have an effect on limiting hematoma expansion when the onset to treatment time was less than or equal to 6 hours. Other subgroups that tended to favor TXA were patients had presence of intraventricular hemorrhage, GCS less than or equal to 12, and an initial systolic blood pressure of less than or equal to 170. The authors were unable to perform a subgroup analysis on patients with positive spot sign due to the small number of participants, so a total of 5 in the entire study that had a positive spot sign. Though this would have been interesting to see if TXA had any impact on those patients, given existing literature and non-NOAC associated ICH, and previous literature not showing any impact in those patients. Overall, these subgroup analyses did yield imprecise estimates as demonstrated by their relatively wide confidence intervals. Based on their results, the authors found no evidence that TXA, in addition to standard of care, limits or prevents hematoma expansion or improves clinical outcomes at 90 days in NOAC-associated ICH. TXA may have this desired effect, however, in patients treated early after onset, particularly within 6 hours. This time-specific benefit falls in line with TXA literature in general. Over the years has demonstrated the earlier the administration, the better and the higher likelihood for seeing some benefit. In terms of my critiques of the study, some strengths were that this was the first RCT that reported hemostatic treatment, specifically with TXA and NOAC-associated ICH. They did implement a double-blind placebo-controlled design, and their primary outcome was consistent with the findings of previous literature, specifically the TICH-2 study that showed some benefit in terms of hematoma expansion when a TXA was used. However, some limitations of the study were its underpowered sample size, primarily occurring due to premature discontinuation of the trial due to a lack of funding. The baseline timing of treatment in the TXA arm was slightly longer than the placebo arm, which may have impacted the results. And finally, the author's inclusion of patients presenting within 12 hours of symptom onset would also be viewed as limitation, given such a longer time to onset compared to previous literature that usually had patients presenting around 4 to 6 hours. In summary, TXA has not been shown to improve hematoma expansion or functional outcomes in NOAC-associated ICH in patients presenting within 12 hours of symptom onset. The study, however, does continue to demonstrate the safe clinical profile of TXA, and larger multi-center trials will be needed to further assess potential benefit of hemostatic treatments on NOAC-associated ICH. I would like to quickly acknowledge my mentors, Jess Corio and Danielle Kvachian-Lindale, for their support and guidance preparing this presentation today, and I'm happy to take any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.